So this is already published in 2010, a American Neurogastroenterology Motility Society review and state of knowledge at that time, and it defined gastroparesis as the presence of delayed gastric emptying in the absence of mechanical obstruction of the stomach, associated with symptoms like fullness, satiety, nausea, vomiting, bloating, and epigastric pain. The epigastric pain is a little bit controversial, but all the black ones around the world, people would agree, yes, this is associated with gastroparesis. And how do you make the diagnosis? You do an upper endoscopy or further radiological imaging showing no obstruction and an emptying test, and you have a number of types of tests available. Scintigraphy is best known, you have breath test, you have smart pill, and if that is significantly delayed, you have a diagnosis of gastroparesis. So the entry point is a little bit different. We have severely delayed emptying. We also have a normal endoscopy, but it's the emptying test that defines gastroparesis. And the most frequent etiologies are idiopathic. There's a big group of diabetics, and then there's drug-induced. And these are some of the drugs inducing gastroparesis. Opioids especially, GLP-1 analogs, but also some antidepressants, some antihypertensives, and so on. And this is also associated with neurological disorders, can occur post-surgically in systemic disorders like scleroderma. But these two upper ones are the big ones. And the NIH-NIDDK consortium collected big groups of patients presumed to have gastroparesis and tested for it. And in those who tested positive for gastroparesis, the consortium collected this group. This is one of the early papers, 416 patients, 2/3 idiopathic, 1/3 diabetic. It shows you the relative prevalence of both of these subgroups.